Hi guys, welcome back. The next organism we're going to talk about is Aspergillosis. This fungus got its movement of glory, especially post-COVID when the media started reported cases of yellow fungus. Now we as doctors obviously do not do any color coding on the fungus per se, but just to set the record straight, what the media was highlighting as the black fungus is mucormycosis, and what they were mentioning as the yellow fungus is the topic that we're studying, Aspergillosis. The conidia of this fungus are present in millions in our environment, and we all keep on breathing it, though the amount of these conidia will vary, especially India being a dusty country. Dust is omnipresent in our houses. You see, every time you come back into your hostel room, you will always find a layer of dust over your computer screen. So because of the dust per se, the conidia are circulating in the environment, and the same happens in our intensive care unit also. So our post COVID patients who had been put on high dosage of steroids, they were anyway immunocompromised, and when they were inhaling this fungus, they were ending up with development of invasive pulmonary aspergilloma that was causing even massive hemoptysis. Another study by PJ Chandigarh showed that the conidia of this fungus can even be present in the hospital beddings. Now, during the COVID outbreak, especially in the month of March, April 2021, because there were so many patients admitted in the hospital in a short time frame, so even the turnaround time of changing of the hospital beddings was getting compromised. So if you do not change the hospital bedding per se, just because the load on the hospital is higher and maybe you're using the same bedsheet for 2 days, then the chances of the fungus growing there is relatively higher, and this was very much documented. So the message here is that aspergillosis, which is caused by Aspergillus fumigatus, niger, and flavus. I'll describe the names in a more detail subsequently, but the three organisms which are incremented or causing this disease are present everywhere, and if they turn dangerous, especially in patients who have had a bone marrow transplantation or solid organ transplantation or post-COVID as I highlighted, then the damage in the lungs can be so bad that you could be having is a zone of consolidation. And you can see the white area, and surrounding this white area there would also be a ground glass area. This ground glass lesion that is present around the dense white area is the hemorrhagic pneumonitis which is occurring. So what I'm highlighting before you and you are comfortable with is halo sign. In fact, lots of time the question on aspergillosis might begin by describing the radiological findings of the patient. That is a post-COVID patient, a post-hematopoietic stem cell transplantation, post-solid organ transplantation. If you encounter a halo sign, you are definitely on your way to making a diagnosis. Though obviously we need to go in for RT-PCR, we need to go in for antigen-based test, and if possible a bronchoalveolar lavage as well. In some cases, the damage might be even more extensive, and you might be able to see a crescent of air around the initial area of consolidation. So air crescent sign and halo sign is one of the important reasons why this topic can be asked to you. Now, obviously, you very well know the fact that halo sign is also read by you with respect to surgery and ENT in cases of CSF otorrhea or CSF rhinorrhea. Like this guy was punched in the face, or let me say he fell down and he was kicked on the side of the head, and he had a middle cranial fossa fracture, fracture of the facial canal, and CSF is coming out of the ear. So if you take this CSF on a handkerchief or even on a filter paper, you would be having the classical halo sign present. As I said, there are three subtypes which are responsible for causing problems. Majority of the questions in the exam on this topic in the previous couple of years have been with respect to Aspergillus fumigatus. This is primarily because this causes not only damage to the lung in the form of an invasive damage, but this is rather more prevalent to cause allergic bronchopulmonary aspergilloma. Now, there are two aspects I want you to remember for allergic bronchopulmonary aspergilloma, though the clinical manifestation I will mention on the subsequent slides. One, as the name suggests, allergy. So you can obviously associate this with bronchial asthma patients. Second, I want you to remember this is associated with cystic fibrosis patients. And the next point I'm not going to write because I'll do that in the later part of the discussion, but listen to my words very carefully, even with double attention of what you're paying right now. If he says, how do you treat allergic bronchopulmonary aspergilloma? Because we're talking about a fungus, I'll obviously use itraconazole. But if he says the word acute exacerbation, This is the allergic reaction to the fungus. So if he says acute exacerbation of ABPA, then the answer is not itraconazole. The answer should be given as steroids. I repeat the fact once again. If you encounter a question, plain straightforward, treatment of ABPA, itraconazole, no issues. If he says acute exacerbation of ABPA, the answer is going to be given as steroids. Apart from this, he would love to ask you about Aspergillus niger, which is angio-invasive. Now he's going to give you a scenario of a diabetic patient. You very well know the fact that patients of diabetes mellitus would be having anyway higher chances of development of infections thanks to the higher concentration of sugar in the tissues. So a diabetic patient is having a cavity in his lung. Initially, I thought it is due to tuberculosis because anyway, tuberculosis is very common in our country. But the problem is that ATT was started, but still the patient is not improving. Rather, he is developing massive hemoptysis. Guys, this organism can coexist in a cavity of tuberculosis, and you would have read about reports saying fungal ball noticed in the cavity which was caused by tuberculosis, and this fungal ball, the growth of the fungus can be actually contributing to damage to the blood vessels, and therefore though I have started anti-tubercular treatment of the patient, still the angio, because ATT will treat tuberculosis, no, it will not treat the fungal infection. So the angio-invasive nature of Aspergillus niger can contribute to massive hemoptysis. So when you read about a patient of diabetes mellitus, let me say who is receiving ATT because he was showing symptoms of tuberculosis but still is having massive hemoptysis, then Aspergillus niger comes in the picture. The third nasty organism here is Aspergillus flavus. Now, this is asked because of primarily one reason that it can contribute to development of sinusitis. And in this time's exam, they even asked about allergic fungal sinusitis. I'll handle that in the subsequent part of the discussion. But the aspects which are to be remembered at this particular junction would be ABP related to fumigatus, niger, as I mentioned, the angio-invasive nature. And for Aspergillus flavus, one miscellaneous fact that can also be remembered is that it is responsible for production of this product aflatoxin, which you very well know is incriminated in development of primary liver cancer, that is hepatocellular cancer. Additional point which I want you to also remember is that though it will sound very silly of me to actually say it, but still I want to highlight because people I've seen making silly mistakes in the exam. It's not hi-fi information, it is straightforward information that is going wrong. So if you read the term thermophilic actinomycosis, then thermophilic actinomyces per se, this is going to be related to hypersensitivity pneumonitis, which is an example of type 4 hypersensitivity reaction. Well, you will read about this thermophilic actinomyces with respect to bagasosis, exposure to sugarcane dust per se. I mean, in the sugarcane dust, this fungus is growing, that is thermophilic actinomyces. So, actinomyces and aspergillus in a pressure cooker situation in the exam can definitely cause errors of judgment. And I've seen people making these silly mistakes. So, I'm just highlighting this fact that thermophilic actinomycetes is what you read with HP, which is an example of type 4 hypersensitivity. Older edition of Harrison used to call it type 3, but currently HP is a type 4 hypersensitivity reaction. The three problem makers are fumigatus, niger, and flavus. And post-COVID, well, once the PGI study showed the fact that hospital beddings were one of the source for development of this fungal infections, then what they did was obviously they hired more nursing staff, they obviously changed the bed sheets more frequently. But over and above this, as I said, dusty environment is where the conidia of this fungus will grow. So they also deployed HEPA filters. These HEPA filters were there anyway present in or outside the operation theater of your hospital or outside the intensive care unit, but we deployed them even outside the routine wards where we were taking care of COVID patients. So what we found was once the HEPA filters were deployed, the dust per se or the particulate matter inside the intensive care unit, inside the wards will dramatically reduce, and because of that, the incidence of infections also went down. Let's just summarize the common risk factors which are documented to contribute to Aspergillus. Though, I mean, the words that I've said are definitely making sense at the moment, but still for the sake of completion, if you describe or if you read about a patient of febrile neutropenia, if he mentions a patient of blood cancer post chemotherapy, or he mentions a patient who's already undergone a bone marrow transplantation, then Aspergillus definitely comes into picture. Then scenarios like AIDS positive patients, steroids, high dosage post-COVID, then patients of COPD, patients who are having some kind of pre-existing lung damage, and cystic fibrosis and asthma are anyway to be remembered because of association with allergic bronchopulmonary aspergilloma. Now, I highlighted this once again because I want to tell you that if invasive pulmonary aspergilloma, the acute presentation of it, acute pulmonary aspergilloma is not detected, then the mortality rate per se with the invasive, I repeat my statement once again, the mortality rate with invasive pulmonary aspergilloma, that is acute pulmonary aspergilloma, can be close to 100%. I'll just give an example. Post-COVID patient deteriorated. Initially, I thought it is pneumothorax, X-ray is normal. In fact, the findings of bronchopulmonary aspergilloma of the acute variety might take some time to appear. The X-ray is normal, but the patient had massive hemoptysis and he expired. So we were wondering what happened, man. Post-COVID, there is a sudden deterioration. Initially, I thought it could be, a possibility of pulmonary embolism because anyway, COVID can contribute to hypercoagulable state, but there was no evidence of pulmonary embolism. Then I thought, okay, fine, it could be ARDS, it could be a development of pneumothorax, no radiological findings matching with that. But it was subsequently on the postmortem evaluation that it was found that he was having extensive fungal infiltration in the lung per se. The mortality rate with invasive pulmonary aspergilloma touches 100%. Lots of time Harrison says that diagnosis is made after the patient has expired. So even if you were fortunate enough to do a bronchoscopy in this patient, run a bronchoalveolar lavage, the report of lavage will take 1 or 2 days to come. By that time the patient might have expired. With chronic pulmonary aspergilloma, when I say the word chronic pulmonary aspergilloma, the possibility is in majority of questions in the exam, he will give you a scenario of a person who is already taking ATT and he's having a cavity in his lung. But when you evaluated this patient with a repeat CT scan because he was having persistent symptoms, you found a fungal ball growing inside the cavity. So both of those infections could be coexisting. The mortality rate could be as much as 50%. But what I say next is very surprising. Harrison says sometimes there might even be spontaneous resolution, very rare, but spontaneous resolution, and patient might cough that fungal ball out. You see, if the cavity will start communicating with the bronchus, by repeated coughing, the fungal ball might actually be thrown into the bronchus and might come up, along with the expectorate. And luckily the patient might even recover as well. If you read about mortality related to allergic bronchopulmonary aspergilloma, as the name itself suggests, the mortality will be on the lower side. I'll be more comfortable with respect to at least the chances of a patient dying. ABPA, the chances of death are relatively lesser. Now, to identify the presence of invasive pulmonary aspergilloma, we need to do a bronchoalveolar lavage, and they might actually give you a slide in the exam in which you will be able to see this fungal hyphae. But then do notice the fact that at some point these fungal hyphae are showing a branching as well. The branching is occurring at relatively 45 degrees. So every time they give you a slide, the standard pink and the blue slide, not the green one that I'm showing on the contralateral side with black broad hyphae. I'm saying the standard pink and the blue slide with thin hyphae. And you are also able to demonstrate the branching which is occurring at 45 degrees. You have to think in terms of Aspergillus infection of the lungs. In contrast, if you look at the image on the right hand side, this is green slide with black fungal hyphae being seen. So this is a silver stain. We are talking about gomori methamine stain being used. In this particular case, the hyphae are relatively thick. And I would like to also state the fact that either you are not able to see any branching, or even if the branching is present, it is at right angles. So maybe the branching part, I'll just write plus minus after it to say that in majority of the descriptions, it is written either the word non-branching or it is written rarely branching at 90 degrees. So do remember the fact that the image on the left hand side branching at 45 degrees is for Aspergillus. And the one on the right hand side would be for mucorales. Either he might write the word mucorales or he might just write mucormycosis. That would be a broad term to describe it. The best way is always for diagnosis of an invasive infection to go in for a bronchoalveolar lavage when it comes to lungs, though there are antigen-based tests as well that I'll explain to you. So now we will focus on the clinical domain per se. As I explained to you, patients of acute pulmonary aspergilloma might be dead by the time the diagnosis is confirmed. So you need to always keep a high index of suspicion in immunocompromised patients. Every time the MCQ begins by saying a post-hemopoietic stem cell transplantation patient, is having development of respiratory distress, and along with this there's usage of accessory muscles respiration, there is fever, there is hemoptysis. You have to keep in your mind aspergillosis coming in the picture, or any fungal infection could be present, but then aspergillus is one which is relatively more common in these patients. So for diagnosis, what are the tests that I'll be doing in this chapter? One would be a antigen based tests. You would have read about this test even in your microbiology classes, that is galactomannan. This is an antigen which is present in the cell wall of this fungus, so galactomannan levels can definitely be evaluated. Apart from this, another test for invasive fungal infections is beta 13 D-glucan test. It is written in majority of MCQs as BDG. BDG, that is beta 13 D for delta, right? D-glucan test. This is anyway useful for invasive fungal infections. I'm just writing IFI here, and the mnemonic for this would be CAP. It will help you pick up candida infection. Then it is aspergillus and pneumocystis jirovecii, but is not useful for diagnosis of mucormycosis. Now my point is that because this test can be present in multiple scenarios, so it will not be an ideal way for diagnosis. I obviously need better evidence. Therefore, I decided to do a HRCT in this post hemopoietic stem cell transplantation patient, and I'll be able to see halo sign. I have already explained to you the reason for this halo will be a hemorrhagic pneumonitis which is occurring around the area of consolidation. The consolidation part will appear extremely white, and relatively less white would be the ground glass appearance surrounding it. And apart from the HRCT part, I obviously can be doing a bronchoalveolar lavage, where I've already shown you that the hyphae would be branching at 45 degrees. So any of the two scenarios, whether he mentions post-COVID, though I have not written post-COVID here because obviously that's not given in the current edition of Harrison as of now. So I'm just going by the standard textbook data, and now comes the treatment. Most of the doctors casually answered liposomal amphotericin B. Guys, we use liposomal amphotericin B for management of our patients who are having mucormycosis. But if you read acute pulmonary aspergilloma, it is voriconazole which is to be given. And then came a very important aspect. What can you give it for prevention of this infection? Because if you know it will occur, why don't you go in for prophylaxis? Now, this prophylaxis is regularly being used in pediatrics, especially post bone marrow transplantation. Pediatricians are using post-conazole. We did the same thing in our post-COVID patients. So post-COVID patients, one, installation of HEPA filters outside the routine wards. Second, prophylactic post-conazole played an important role. There are no recommendations for post-conazole post-COVID, right? This was just started on EUA, emergency use authorization. But what I've written on the slide is definitely documented in Harrison. Post hemopoietic stem cell transplantation, a person can have high incidence or development of aspergillus in the initial few weeks. So it will always be good advice to not only, go ahead with the barrier nursing, but over and above this, prophylactic post-conazole has to be used. So allergic bronchopulmonary aspergilloma most of the time will be having very striking manifestations. In fact, what I say next will surprise you even further. He says in some cases the deterioration may occur so fast that by the time the diagnosis is made, like I said, lavage report will come after from the microbiology department after 2-3 days. By that time the patient might have even died. Let us now compare this with a condition where the mortality rate would be 50% of what I described for acute pulmonary aspergilloma, chronic pulmonary aspergillosis, CPA. Most of the time, there would be a cavity in the lung, cavitation would be present along with a fungal ball, and this fungal ball can be cuffed out in the sputum of the patient as well. Both Aspergillus fumigatus and Aspergillus niger are responsible for causing chronic pulmonary aspergilloma. There is a high incidence of misdiagnosis of this condition. Now let's look at what are the conditions with which CPA can be misdiagnosed. So one can be sarcoidosis, because this condition would be having non-caseating granulomas in the lung. So radiological findings might initially might make you think, especially if you're having a hilar lymphadenopathy with some reticular opacities, you might think that this is sarcoidosis. Turned out the fact that it was a fungal infection. So we obviously need to keep that in mind. Infections with atypical mycobacteria, sarcoidosis, are to be kept in your mind always when you're reading about CPA. In fact, if it's not diagnosed, the chances of massive hemoptysis are relatively more, which I've already explained to you with respect to Aspergillus niger, which is relatively angio-invasive. Even rheumatoid lung nodules can be initially thought of as either a fungal infection or vice versa. So just remember the three important misdiagnoses in this case with CPA: sarcoidosis, atypical mycobacteria, and rheumatoid nodules. And a lot of these patients might have received biologicals also. That's I'm saying from the COVID situation, like we did use tocilizumab in a large number of patients, and lots of biologicals were actually used. So if you are gonna have post-biological usage, a person having a cavity in the lung, reactivation of tuberculosis, then a fungal ball can definitely develop and can contribute to problems for the person. The next manifestation that I'll describe for this condition would be that of ABPA, allergic bronchopulmonary aspergilloma, but we can have a look at a couple of images here. One, you definitely can notice that there's a cavitation in the lung and there's a fungal ball which is growing inside, which might be referred to as aspergilloma. The term aspergilloma is an alternative one for chronic pulmonary aspergillosis. In contrast, you could be having the classical halo sign, which I have already highlighted. There's a hemorrhagic pneumonitis which is present, and then could be air crescent sign. I just thought I'll show these images once again. And now you will see an image which is totally starkly in contrast to the ones that I've highlighted. If you look at the current image that I am showing and I'm drawing an arrow at, you will notice that there is a evidence of bronchiectasis. You can see the dilated airways, and inside this dilated airways there is incipitated mucus. So in case they wanna ask you regarding allergic bronchopulmonary aspergilloma, ABPA, he will always use the term central bronchiectasis. I repeat the fact, he'll always use the word central bronchiectasis. You will also hear the term hyper attenuated airways. This is mainly to represent the incipitated mucus which is present in this condition. So let's have a look at some important diagnostic criteria for allergic bronchopulmonary aspergilloma. As I said, this is a known case of asthma or cystic fibrosis. Now, cystic fibrosis patients can obviously die, in the first few years of life because of recurrent pneumonia. But with good medical care nowadays, we are able to ensure that they reach up to teenage age group. So why are you suspecting ABPA? In an asthmatic, he says, sir, I am having tremendous amount of coughing for past couple of weeks. You have already used large amount of mucolytics in this patient, but he says, sir, in spite of mucolytics, I'm not having relief. So coughing bouts, these coughing bouts are mainly triggered by episodes of bronchial obstruction, which is occurring with the mucus plugs. Please remember the fact that ABPA is an allergic reaction to the fungus. It's a reaction to the colonization of the airways by the fungus, but I'm not going to use the word infection in this case. I'm not saying that there is any consolidation in the lungs. I'm not saying there's infiltration in the lungs. All I'm saying is the airways are the ones which are colonized and they're reacting to the presence of the fungus. So there is episodes of bronchial obstruction. And for this, I have used N-acetylcysteine and traditional mucolytics already in the patient, but to no relief. So I'll also describe what we'll give for the treatment of this patient. He says post the mucolytic usage, he's having thick tenacious sputum. It's very sticky. It is taking the shape of the airway. So I can also use the word casts in this case. I repeat the fact once again, this is an asthmatic. He is saying the fact that, doctor, I'm not having an exacerbation at the moment, but I have a large amount of coughing bouts which contribute to distress. And obviously, I mean, any person, if he's coughing for a long time, he might even complain of shortness of breath. So I decided to do a quick workup of this guy. The first thing I noticed was his eosinophil count was dramatically increased. Now, before we go forwards, I want to tell you that if a question begins by saying an asthmatic having a eosinophilia and X-rays showing fleeting pulmonary opacities, I repeat the fact once again, I can use a different slide for that. If you read a question that talks about an asthmatic patient, he says the fact that the X-ray of this patient is showing either fleeting pulmonary opacities or a miliary picture / either of the two might be written, and eosinophil count of the patient is shooting up. Normal eosinophil count is about 40 to 400. Here the eosinophil count is, let me say, 5000. Then the diagnosis of this patient should be given as tropical pulmonary eosinophilia. This was a question that was asked in this time's NEET 2021 exam. So there are two domains that I'm teaching you for asthmatic. One is obviously the deterioration status asthmatic part that I've handled in asthma. But today I'm teaching you that if you read about an asthmatic having fleeting pulmonary opacity, eosinophilia, tropical pulmonary eosinophilia because of migration of microfilaria via the lungs. In contrast, if you read a question where an asthmatic is having coughing bouts, you gave N-acetylcysteine to the patient and he says, sir, there is thick tenacious sputum that takes the shape of the airways. I also feel short of breath. You found eosinophilia. So you ordered a HRCT of this guy and the classical term was written central bronchiectasis. I'm just using a thicker font size to highlight the pickup points in the MCQ. I'm an asthmatic patient, coughing bouts, then central bronchiectasis. The diagnosis is not tropical pulmonary eosinophilia. It would be given as ABPA. Over and above for diagnosis, I also need to run some other tests which can confirm that this is an allergic reaction to the fungus. So I will be checking for immunoglobulin E levels for Aspergillus. I repeat the fact, I'm not talking about infection, I'm talking about hypersensitivity reaction to the fungus per se. So if I demonstrate IgE levels for Aspergillus and if I check total immunoglobulin E levels, they will definitely be skyrocketing. As far as the values of immunoglobulin E are concerned, there's a slight error or a misprint in Harrison. It is actually more than 1000 nanograms per ml, but in Harrison it is written not in nanograms, it is rather written as 1000 international units. I want to repeat the fact once again. It is a small error, a typographical error that's present in the textbook. Don't worry about that. I mean, actually in the textbook, it is written as international units. It is more than 416 international units per ml or more than 1000 nanogram per ml. So we need to demonstrate this. I mean, these points, why they're important for you to remember and why I'm using a thicker font size is because these are the points that he will ask you in the exam. The points are you need to demonstrate that the patient is having high levels of immunoglobulin E, total immunoglobulin E is elevated, or if this testing is not available in your hospital, you can go in for a skin prick test for Aspergillus fumigatus as well. So if you read these terms given in a question along with central bronchiectasis and an asthmatic and the clinical profile that I explained to you, your answer would be given as allergic bronchopulmonary aspergilloma. Listen to my next words even more carefully. There is a possibility that you might be getting a question in which the same profile is given, asthmatic with the coughing bouts. But these criteria, the ones that I put 3 tick marks against, these criteria are not satisfied. Maybe 2 of them may be given. All 3 may not be given. He might just mention the fact that positive skin prick test is present, but the remaining 2 are not documented and there's no central bronchiectasis is also written. In those scenarios, if the criteria are not met, the ones that I put tick mark against, I repeat the facts once again, IgE against Aspergillus, total IgE levels elevated, and the third one being positive skin prick test. If the 3 criteria are not given in the question, all 3 should be given. If none of these are given or maybe one of them is given, then you will say in the MCQ, patient is having severe asthma with fungal sensitization. This would be SAFS. And why these 2 terms are important is because both ABPA and severe asthma with fungal sensitization, they constitute a spectrum disease that is called as fungal asthma. I mean, when you read the term for first time, it looks very surprisingly fungal asthma, but then it's a colonization in the airways and then a hypersensitivity reaction to the fungus. So fungal asthma includes 2 terms, ABPA and SAFS. How do you differentiate between the 2? The initial profile would be same. If all the 3 criteria that I've highlighted, I'll just put a box around them, are present in a question, you will say ABPA. If they're not given, you will say there's going to be a presence of severe asthma with fungal sensitization per se. Over and above this, they definitely can put up questions even on Aspergillus niger. Not only can contribute to damage in the lungs, it can also contribute to allergic fungal sinusitis. Now, I am aware of the fact that allergic fungal sinusitis is what you read even in ENT, but I'll just try to do my part here. I mean, this person is suffering from complaints of sinusitis, like he has forehead pain or maybe pain with respect to the maxillary sinus. So chronic sinusitis has been present in this patient, and he also says that the doctor has prescribed me antibiotics multiple times, thinking it to be an initial acute sinusitis. So chronic sinusitis unresponsive to antibiotics. That would be one of the initial presentation. Over and above this, this chap is also having nasal polyps. I mean, you are very well aware of the types of nasal polyps from ENT, but what I'm saying is this guy is distressed by the fact that he has visited so many physicians and ENT specialists. He suffers from chronic sinusitis. There is nasal polyps which have been documented. When the ENT specialist did a nasal endoscopy or rhinoscopy, there was a congested nasal mucosa. And the workup of this patient, when we did a CT or MRI of the paranasal sinuses, not an X-ray, but a CT or MRI of the paranasal sinuses, the sinuses are full of mucoid material. So when you read this kind of information given in a question, you have to think in terms of this could be a fungal manifestation, allergic fungal sinusitis occurring in a patient. Even these patients will be having eosinophilia. So eosinophilia has come up in our discussion 3 times. I repeat the terminologies where eosinophilia has been used: allergic bronchopulmonary aspergilloma, then tropical pulmonary eosinophilia, and allergic fungal sinusitis. Along with this, traditionally in asthma, we read about charcoal-laden crystals. These are basically cell wall of the dead eosinophils. We read about charcoal-laden crystals in asthma, but today I'm talking about charcoal-laden crystals being present in the nasal secretions per se. Then allergic fungal sinusitis is to be considered, and the treatment for this condition would be steroids plus minus ethmoidectomy. I mean, that ethmoidectomy, whether it's required or not, and indications for that would be explained by the ENT person. But I definitely want you to remember the fact that with respect to Aspergillus niger, even allergic fungal sinusitis can be described. From the historical perspective, for diagnosis of allergic bronchopulmonary aspergilloma, the criteria which are present are called as Rosenberg-Patterson criteria. The details I've already discussed with you, the specifics of it. And lastly, to just summarize the treatment for these patients, if the MCQ begins by saying what is the main treatment of allergic bronchopulmonary aspergilloma, your answer would be given as itraconazole. Remember, it was a colonization of the airways causing thick mucus getting insipided, contributing to central bronchiectasis. But if he slightly modifies the MCQ into acute exacerbation, this is what they have done in a large number of exams. Acute exacerbation of allergic bronchopulmonary aspergilloma, then the answer would be steroids. And you can very well understand for any physician to start steroids, especially with respect to cystic fibrosis patient, because ABPA definitely can not only occur in asthmatics but can occur in cystic fibrosis also. And cystic fibrosis anyway is a patient of recurrent pulmonary infection. So it's a very difficult, dicey situation for any physician, because on one hand you're having infections, on the other hand you are having to give steroids. So we need to develop a tight balance so that we are able to get the patient out of this mess. I also want to highlight that if the question talks about a patient having invasive pulmonary aspergilloma, that is the acute presentation, he might deliberately use the word subacute also. There's an artificial cutoff present. In acute, it is within 1 month manifestations occurring, like post-COVID within 1 month or post-bone marrow transplantation within 1 month, and subacute is 1 to 3 months. But the bottom line is, if a person is documented to have an invasive pulmonary aspergilloma, how would I suspect that? Immunocompromised patient having positive galactomannan test, beta-1,3-glucan test. BAL report might still be pending, but I'll still start the patient on voriconazole. And if he says, how would you prevent this from happening? Then I've already explained to you, it is postconazole. In Harrison, this protocol is mentioned mainly for patients of hematopoietic stem cell transplantation treatment and the prevention part, and the same thing was extrapolated even in patients of COVID-19. So these are a couple of details which I have tried to integrate with microbiology, and I would suggest you to read up the same topic from microbiology, initially the fungal infections, and then listen to my inputs also, so that you will be able to improve your strike rate. So keep the focus on, guys, keep on studying on a daily basis, keep on learning new facts every day, and gradually you will build up to that crescendo, that threshold, where you will be able to solve MCQs on a regular basis and will be able to ace the exam with flying colors. Thank you so much for your patience and hearing me out.